Hi, so I welcome you all to this channel. So I am Dr. Trupti Pai. I am Associate Professor and Pathologist at Tata Memorial Hospital, Mumbai. Today we will have some talk on the pathology aspect from the lung cancer point of view. So when it comes to lung cancer diagnosis, we all know that the molecular testing is most important from the management point of view. But today we will just take one step back and will focus on the pathology aspect. So before going on to molecular testing, a detailed histopathological examination of the tumor tissue is very important. So we will see how we go about this histopathology and what information we come to know from this. So whenever a patient has a tumor on imaging, we get samples, for example, biopsies, tissue biopsies. Now this tissue biopsies can be from the lung tumor, or it can be anywhere from the lymph node or any different metastatic site. So once we get the tumor tissue, what we do is that there is a tissue processing. So we put the tumor tissue biopsy sample in a formalin as early as possible, and we have certain criteria which should be taken care of, that is called as pre-analytical things. If certain things, like if the biopsy is put in the formalin within 1 hour of taking out from the body, it is kept for at least 6 to 24 hours in formalin, and which type of formalin, it is 10% neutral buffer formalin. So if all this is taken care of, it leads to a very good tissue processing. So after a tissue is processed, a paraffin block is made, and from this paraffin block, now this becomes the most important archival material for both the histopathology as well as the molecular testing, for subsequent molecular testing. So after we get a paraffin block, we take sections and we stain and see under the microscope. So what are the things that we see under the microscope? So if we see lung cancer, there will be different types of lung cancer. So are all of this very bad? So that we come from, with that we come to know from the histopathological examination. So there are different types of cancers. Some are adenocarcinomas, some are squamous carcinomas, some are lymphomas, some are sarcomas. So that is very important, which type of tumor it is. So why this is important? Because if in today's date you have a adenocarcinoma, you will do different other molecular tests on these samples. Does that mean that in the rest of the tumors we don't do? No. We can do still molecular testing on squamous carcinoma and some subtypes of sarcoma. But from management point of view, what has been a paradigm shift in the management is we seen in adenocarcinoma and some cases of squamous carcinomas. So when you get a tumor of adenocarcinoma, what you do, you say what is the tumor, what are the patterns what are seen, and then you do immunohistochemistry analysis. So in the histopathological examination, we will take one example. If we have a specimen of adenocarcinoma, we will do certain IHC markers. We can do TTF1, P40, which are the diagnostic markers, which helps in defining which subtypes of cancer it is. And also we do biomarker testing. We do UL cross by IHC or FISH. Also we do EGFR by PCR. Now all this can be combined, and then can be a multi-gene assessment by NGS. So in today's date, if we see pathology, it is not just the tumor diagnosis, but you have to optimally utilize the tumor tissue and preserve as much tissue as possible for the subsequent molecular testing. Now, as in molecular testing, we have different platforms. As I said, we have IHC, we have FISH, we have PCR, and we have large panel testing, NGS. So whenever a patient gets a report of adenocarcinoma and the tumor is widespread, the clinician is going to ask for NGS testing, and which is very important. So sometimes what happens in this tissue processing and diagnosis, the tumor tissue is less. Even if the biopsies are long, the tumor content in this is less. So we have to ask for, so we say it is inadequate for further testing. Sometimes the patient has to undergo a repeat testing, a repeat biopsy testing. Can other samples be used for this? For example, patient has ascitic fluid, patient has pleural fluid, blood can be utilized. So these are other different samples which can be utilized for the pathological examination and for subsequent molecular testing. So a repeat biopsy is asked for. So my point is here that even if the diagnosis is made and molecular testing is not possible because of inadequate tissue, please go ahead with repeat testing and make the most out of it, because all these driver genes which are being tested by this molecular test, you have different oral tablets and targeted treatment available. And if we treat such patients or these tumors with this targeted treatment, the benefit of survival is very good, and there is a good tolerance because these are oral tablets and patient can get rid of even chemotherapy. So it is very important to go ahead with adequate histopathological and subsequent molecular testing. So these were some certain parameters from the biopsy point of view. So point to note here is that whenever the patient is already on targeted treatment, after some days, if patient progresses or there is a recurrence or there is a residual thing, again a repeat biopsy may be asked or a testing may be done in blood. Nevertheless, patient should make use of this opportunity, go for repeat testing and subsequent repeat molecular testing. So this was about in general a pathology from in a advanced cancer center. What if the patient is a early stage or a operable? Still a biopsy is needed for a diagnosis before you start any cancer related treatment. Again on biopsy, you will run certain IHC marker, you will see the histomorphology and you will say which is the subtype of tumor. If for example in this case, if the patient goes for surgery, there are again surgical different histopathological parameters. There are different ways of grossing, different tissue processing, larger time in formalin and subsequent sectioning. So here in resection sample, what is important? Here in resection, it is not just the diagnosis. You will say which is the tumor type, which are different tumor patterns, where all it is going, is it involving pleura, is it involving the main bronchus, what is the adjacent lung parenchyma, are there different tumor nodules. So all these are not just the diagnosis point of view, but also which things like which determine the prognosis and subsequent prediction of the treatment. So how many nodes are involved, if the tumor is going beyond the lymph nodes. So these are the different histopathological parameters, and depending on this, even if the patient, if it has underwent a surgery, there can be a need for adjuvant as well as in some cases neoadjuvant chemotherapy or radiation. So for more such kind of information, please join Lung Connect.